Acute appendicitis. 100 essential questions and answers. Expert insights on anatomy, diagnosis, surgery, and controversies. Welcome to the Everything Surgery podcast. Today, we'll be tackling 100 of the most frequently asked questions about the management of acute appendicitis, covering everything from anatomy and pathophysiology to diagnosis, surgery, complications, and challenging controversies. Pause video when you hear the word answer to attempt answer. Let's begin. Anatomy and pathophysiology question. What is acute appendicitis? Answer. Acute appendicitis is the sudden inflammation of the appendix, usually caused by obstruction from a fecalith or lymphoid hyperplasia. Question. Where is the appendix most commonly located? Answer. The retrocecal position is most common, 65%, followed by pelvic, 30%, subcecal, 2%, and preilial or postileal, 1%. Question. Could you explain McBurney's point? Answer. Certainly. McBurney's point is located 2/3 of the distance from the umbilicus to the anterior superior iliac spine, often the site of maximal tenderness in appendicitis. Question. What's the primary blood supply to the appendix? Answer. The appendicular artery, a branch of the iliac artery from the superior mesenteric artery. Question. How does appendicitis develop? Answer. It begins with obstruction, followed by bacterial overgrowth, inflammation, ischemia, and eventual perforation if untreated. Question. What is a fecalith? Answer. A fecalith is a hardened piece of stool that blocks the lumen of the appendix. Question. What role does lymphoid hyperplasia play? Answer. Lymphoid hyperplasia is a common cause in children and young adults, typically following viral infections. Question. What's the lifetime risk of appendicitis? Answer. Approximately 7%, with a higher incidence among males and young adults. Question. What is meant by appendiceal stomp? Answer. It refers to the residual base left after an appendectomy. Question. What is the histological hallmark of appendicitis? Answer. Neutrophilic infiltration of the muscularis propria. Diagnosis and evaluation question. What are the typical symptoms of appendicitis? Answer. Classically, it starts with periumbilical pain that migrates to the right lower quadrant, accompanied by anorexia, nausea or vomiting, and low-grade fever. Question. What is Rovsing's sign? Answer. Right lower quadrant pain on palpation of the left lower quadrant, indicating peritoneal irritation. Question. How about the psoas and obturator signs? Answer. The psoas sign is pain on right hip extension, often with a retrocecal appendix. The obturator sign is pain on internal rotation of the flexed right hip, suggesting a pelvic appendix. Question. What is Dunphy's sign? Answer. Increased pain with coughing, a sign of peritoneal irritation. Question. Could you explain the Alvarado score? Answer. It's a diagnostic tool assessing symptoms and lab findings. A score of 7 or higher suggests a high likelihood of appendicitis. Question. Is there a pediatric scoring system? Answer. Yes. The Pediatric Appendicitis Score, a modified Alvarado for children. Question. When should imaging be considered? Answer. Imaging is best for atypical presentations or for pediatric, elderly, and pregnant patients. Question. Which imaging studies are preferred? Answer. CT scans offer the highest accuracy. Ultrasound is preferred for children and pregnancy, while MRI can be used in pregnancy as well. Question. What are the key CT and ultrasound findings? Answer. On CT, look for an appendiceal diameter over 6 mm, wall thickening, and fat stranding. On ultrasound, a non-compressible appendix over 6 mm with hyperemia and free fluid. Question. What is the role of laboratory tests? Answer. Leukocytosis, neutrophilia, and elevated CRP can support the diagnosis. Question. What is an appendicolith? Answer. It's a radiopaque stone seen on imaging, raising the risk of perforation. Question. Which conditions can mimic appendicitis? Answer. Mesenteric adenitis, diverticulitis, pelvic inflammatory disease, ovarian torsion, and Crohn's disease. Question. Why is appendicitis rare in infants? Answer. Their appendix is funnel-shaped, reducing the risk of obstruction. Surgical management question. What is the gold standard for treatment? Answer. Surgical removal, appendectomy, either open or laparoscopic. Question. When is non-operative management appropriate? Answer. In select, uncomplicated cases, an initial course of antibiotics may be considered. Question. What antibiotics are typically used? Answer. Common regimens include ceftriaxone plus metronidazole, or piperacillin tazobactam. Question: what are laparoscopic appendectomy's main benefits? Answer: less postoperative pain, quicker recovery, lower surgical site infection rates, and better visualization. Question: when would an open appendectomy be preferred? Answer: in cases of perforation, abscess, dense adhesions, or patient instability. Question: which incisions are used for open appendectomy? Answer: the gridiron, McBurney or Rocky Davis, transverse incision. Question: how is the appendix removed surgically? Answer: the base is ligated with suture or stapler, and the mesoappendix is ligated separately to prevent bleeding. Question: what is a retrograde appendectomy? Answer: that's when the base is divided first. Useful for complex cases. Question: what is Sills appendectomy? Answer: single incision laparoscopic surgery, through the umbilicus. Question: what does NOM refer to? Answer: non-operative management, antibiotics alone. About 30% of patients may have recurrence within 1 year. Question: what is interval appendectomy? Answer: elective surgery performed weeks after initial abscess drainage. Question: when is percutaneous drainage indicated? Answer: for appendiceal abscesses larger than 3 centimeters. Question: should the appendiceal stump be inverted? Answer: it's controversial. No definitive benefit has been shown. Question: is there a role for robotic surgery? Answer: similar benefits to laparoscopy, but with higher costs. Complications. Question: what's the most common complication after appendectomy? Answer: surgical site infection. Question: what is stump appendicitis? Answer: recurrence of inflammation in the residual appendix. Question: what is the risk of perforation? Answer: about 20%, particularly in young children and the elderly. Question: what's an appendiceal abscess? Answer: localized pus collection due to perforation. Question: what is peritonitis? Answer: generalized inflammation of the peritoneum, requiring urgent surgical intervention. Question: what is the wound infection rate? Answer: between 5% and 10%, higher with open surgery. Question: what is an enterocutaneous fistula? Answer: a rare complication caused by leakage from the appendiceal stump. Question: how about postoperative ileus? Answer: it's common and typically resolves within 2 to 3 days. Question: what is portal pyemia? Answer: also known as pylophlebitis. It's a rare but deadly septic thrombophlebitis of the portal vein. Question: what's the mortality rate for appendicitis? Answer: less than 1%, but higher in cases of perforation. Special scenarios. Question: how is appendicitis managed during pregnancy? Answer: laparoscopic surgery is preferred during the first and second trimesters. Question: what about imaging in pregnant patients? Answer: ultrasound is first line, MRI if results are inconclusive. Question: how does appendicitis present in the elderly? Answer: symptoms are often atypical, with less pain and a higher risk of perforation. Question: how does it present in children? Answer: more vomiting and higher fevers are typical. Question: what is chronic appendicitis? Answer: rare, with recurrent right lower quadrant pain. Diagnosis of exclusion. Question: what is tip appendicitis? Answer: inflammation confined to the distal tip, making diagnosis difficult. Question: what's the cancer risk in appendicitis? Answer: around 1%, including carcinoid tumors and adenocarcinoma. Question: when is right hemicolectomy indicated? Answer: for tumors at the base or large carcinoids over 2 centimeters. Controversies and advanced topics. Question: is non-operative management superior to surgery? Answer: surgery remains the gold standard, as non-operative management has a 30% recurrence rate at 1 year. Question: can all patients be diagnosed clinically, or should everyone get a CT scan? Answer: classic cases can be diagnosed clinically. Imaging is reserved for atypical presentations. Question: what is the negative appendectomy rate? Answer: about 10 to 15%, higher in women due to gynecologic conditions mimicking appendicitis. Question: should incidental appendectomy be performed? Answer: generally, no, unless the patient is at high risk, for example, familial polyposis. Miscellaneous question: how long is the typical hospital stay post-op? Answer: 1 to 2 days for laparoscopic surgery, longer for cases with perforation. Question: when can patients resume eating and return to work? Answer. Eating can often resume the same day for laparoscopy, and work can typically resume in 1 to 2 weeks. Question. What is the most common cause of death in appendicitis? Answer. Sepsis due to perforation. Thank you for joining our in-depth discussion on acute appendicitis. Be sure to subscribe for more expert answers to your surgical questions.